Hello, everyone. This week we're going to be covering Chapter 6. Chapter 6 talks about document standards in the patient record. I've split these video lectures into 3 video lectures instead of giving you one large one. I think that seems to work better. And hearing back from you, that seems to be a little bit easier to digest. So the first video lecture, we're going to be talking about documentation standards related to the patient record, particularly the hospital record. We'll be talking about the value of the hospital record. We'll give you some examples, some key documentation standards. We'll talk a little bit about the hospital record structure, what exactly history and physical does, and what have you. And if you answer the questions that pop up on screen as usual, they'll help you understand and remember the material so be ready to go and know it, not just for the quiz, but going forward, because you'll be working with health information and health record content for a long, long time. Let's get started. Okay, as mentioned, this is covering documentation guidelines, and we'll be covering inpatient, outpatient, and the physician's office. When we use the term providers, we think normally of physicians, but we're talking about all different types of providers in all different types of settings. And this includes hospitals, ambulatory surgery, medical offices, you name it. And all these providers, whether they're physicians, PAs, or whatever they are, they're responsible for maintaining the record for each patient. And if it's an accredited, for example, a hospital that's accredited by the Joint Commission, they need to comply with minimal standards that affect patient record keeping, right? In addition, there are federal and state laws, including regulations such as the Medicare conditions for participation, which we commonly refer to as COP, provide guidance about patient record content requirements. And this pertains to both inpatient and outpatient, because again, Joint Commission doesn't just oversee hospitals. So in order to comply with these standards, most facilities have a committee. We used to call it, when I first started off in health information management, the Medical Record Committee. Now it's called the HIM Committee. Most places, other places have different names for them. Joint Commission standards require that patient records contain patient-specific information appropriate to the care, treatment, assessment, and any services that are provided for the patient. These conditions of participation also require hospitals to establish a medical record service that has administrative oversight for all medical records. And the hospital must maintain a medical record for each inpatient and outpatient, period. And a discussion. So what does this mean? That means if you go to Riverbend, even if you're going for, quote, just an x-ray or just imaging or what have you, they will give you a unique medical record number for them. And ideally, if you come back and you're admitted for whatever reason to Riverbend, you will use that medical record number, right? So we have a medical record that's established for each unique inpatient and outpatient. Thirdly, the medical records have to be written, completed, properly filed, properly retained, and accessible. So what does this mean? In a paper-based world, this meant that discharge summaries, history and physical, op reports, consults normally were dictated, meaning the physician sometimes would keep little notes on index cards and dictate. In other words, speak into a phone or tape recording machine, and a transcriptionist would type these, right? So they type up the discharge summary, the physician or other provider would review it and assign it. It's changed a little bit now with the HRs, but they still need to be written, completed promptly, accessible, and retained, right? So a little bit different with EHR systems, but the premise is basically the same. We can't use an EHR system that's down 12 hours a day between 6 p.m. and 6 a.m. Records entries have to be legible, complete, and authenticated and dated by the person, meaning their name, discipline, whether they're an MD, PA, nurse practitioner, whatever it is, responsible for ordering, providing, and evaluating the services furnished. So what does this mean? In real terms, it means that you have to be able to read it and things have to be dated and authenticated. In a paper world, we saw a lot of hospitals hire medical transcriptionists in the emergency room because given the rushed, chaotic nature that sometimes emergency departments have, a lot of things are barely legible. As a result, you couldn't really code them, right? And a lot of facilities found that by hiring a transcriptionist to make this legible, their reimbursement, their data quality, their data integrity was much, much better. Now in an EHR world, I don't have a problem with reading things as much, but sometimes things like verbal orders still need to be authenticated and signed electronically. And then the author of each entry has to be identified and we have to authenticate their entry, meaning signatures, written initials, or computer entries. So now in a paper world, once a provider was cleared by medical staff credentialing, they got a number, they would sign, we'd get a signature card and all this kind of stuff. Now, of course, they get access to an EHR, they get role-based access so they can make entries a little bit easier, but the premise is basically the same. The patient record is a valuable tool that documents the care and treatment of the patient, and it serves both administrative and clinical purposes. With paper charts, we used to print what we called face sheets, and that would have the patient's demographic information and the attending physician's name, date of admission, and it would be something that would be line printed. Now it's a little bit different. Patient records, however, still contain patient identification, patient's name, their medical record number, their date of birth, their account number, all those different types of things. Some patients, and we see this a lot of times when I worked at Stanford, celebrities would be admitted to the hospital for medical treatment and they didn't want to have a whole battalion of people chasing them around, coming by the ward and disrupting their care, or they're upsetting their family, so they'd be admitted under an assumed name. And that practice still is with us in various places. But the bottom line is we have to have some sort of way of going back and identifying that person in the master patient index as an AKA, meaning also known as. In addition to documenting information about the patient and the physician, we also have to document the name of the facility, telephone number, address. That has to be in the patient record. It doesn't have to be on every screen, every page, but we have to have that information in the electronic health record. And providers are trained when they're in medical school and doing their internship, residency, fellowship as to different guidelines that you can see in your text on table 6.1 that ensure we have quality, meaningful documentation. And again, we get down into the fine level of detail saying that all references to a date have to be written in the month, day, year format. and all these other things. I'd strongly advise taking a close look at Table 6.1 to make sure you understand some of these documentation guidelines. You'll keep seeing them again and again and again. And again, while Joint Commission doesn't require a face sheet, and sometimes depending on the electronic health record system you're using, they may refer to it as a snapshot or the first screen or what have you, but it basically has the same kind of information. And if you recall our discussion about the Uniform Hospital Discharge Data Set, that's the minimum core set that you should see. And it's normally on one screen or set of screens in the EHR, much like it would be in the very first page of a paper chart. So what do those types of things include? Well, you can see them on table 6-2, but here's a short list of them. They include such things as the admitting diagnosis, the principal diagnosis, the final diagnosis, and any secondary diagnoses. They'll discuss comorbidities, complications, the principal procedure, the secondary procedure, and the patient's authorization to release information from reimbursement, and a attestation statement, which means that it verifies that all the diagnoses and procedures that were documented in coding are legitimate. They'll include advanced directives, which we'll get into a little bit later. And again, some of these things you will see again and again and again. And for those of you who are going to take coding in the near future, this is one to pay special attention to, the principal diagnosis being the admission that the reason the patient was admitted after study that caused the condition. And then also the principal procedure. So bear those things in mind. One of the other things we see a lot in health records is consents, and these are several different types. One, we have a consent to admission. So it's basically consenting to treatment. We also have authorizations to release information so the hospital can get paid. You can see that in figure 6.9. If any personal property is collected and stored, there's a consent for that. Birth certificates, death certificates. So all these things kind of fall under that kind of global umbrella. And that's all I have for you for right now. Come back for our next video lecture. We're going to get more into the finer details about documentation requirements for not just inpatient, but medical office and other outpatient services. We'll see you then.